are several components in the bill that match the task force. As you may recall, I was a member of that task force. Unfortunately, we've decided that the time for talking has ended and the time for action has started. And we're going to move forward with this bill aggressively, pursue the goals and objectives not only of the task force, but those which Dr. Johnson and myself feel need to be achieved in order to start saving lives.
You did have that task force last year, and this is, as you point out, a life and death problem. Why didn't legislators pass something last year?
Well, that's a good question, isn't it?
Do you want that one?
No, you're going to do a fine job.
All I can tell you is that we're here today, and we control the agenda of this House. And we are not backing down from this difficult issue for any reason. People in Ohio are dying, and as a doctor and a pharmacist, we will not tolerate that. We will move this agenda forward.
I will tell you that over the last several years, Dave Burke has met with everyone that is affected by this epidemic, and he's met hour upon hour with folks, bringing them to the table, decision makers, whether from the pharmacies or whoever, and law enforcement working with them. And so this legislation has been vetted with all of them. They understand the necessity of it, and that's why we're here today.
I'd also like to say that when I was asked, when I was running for state representative of the 89th district, what I thought the most pressing problem was in Southern Ohio, many people thought I would say jobs, because jobs is a chronic problem. We're always 3 or 4, even 5% above the unemployment rate of the state in Southern Ohio, particularly side of the county. But what I said was it was prescription drug abuse, because it's killing people. The mortality is phenomenal. The morbidity, the illness, the people in the ER, the people who are losing time from work, the people who can't work because they're hooked on drugs, elder abuse, child abuse, all the things that are going on down there, that has to be priority number one. And as an osteopathic physician, my point of view comes at this from a holistic perspective. I look at everything when I look at the problem. I want to heal our community. Yes, I want jobs for our community, but it's awfully hard to correct the job problem if you got this social problem going on at the same time. It's a huge millstone that's dragging us back and keeping us from progressing. Priority number one for us is to decrease the number of deaths, decrease the number of people who are going to the ER because they're having this problem, and shut down pill mills. Legislation is not a silver bullet. What it's really going to take is legislation that can be reassessed to see how we're doing with it. It may take follow-on legislation. It may take tweaking of legislation. But it will also take concerted effort of the people at home. And they're coming together like they never have before. Clergy, school teachers, law enforcement, judges, people from across the spectrum. And those ladies we talked about from Solace who have lost their children to this problem. And it's really going to rely on us keeping that group together of people in the local area and assisting them, giving them the resources they need from the state level.
Of course, generally you think about going to your neighborhood pharmacy after you've seen your local doctor. But there's been a recent trend in the last year or two of folks that have gone down to Southern Ohio and Terry Johnson's neck of the woods and obtained prescriptions for controlled substances and had difficulty filling those prescriptions. As such, they circulate out throughout the state trying to get them filled. So it's not uncommon to see a prescription that was written that day or the day prior to show up in Marysville from somebody who maybe lives in Newark or Cambridge or Springfield. I refuse to take part in something that's not a care-coordinated effort, which means the pharmacist, the physician, and the patient are working together to improve someone's life. This is simply about taking controlled substances.
And Dave, if I could add, in any small community, such as Scioto County or Adams County or Lawrence County or Pike County, that we're very familiar with down there, a necessary check and balance on what's prescribed is the local pharmacy. The pharmacist has a perfect right to say, I don't want to fill that medication. I don't think it's a proper medication. Get on the phone, talk to the doc, and then if the doctor has a convincing reason, oh, I understand. Okay, yeah, we are going to fill that. I didn't see that. Or, more likely, what's been happening down there, the pharmacies called these doctors, couldn't work it out, said this is not a good prescription, so they stopped prescribing. And then these folks went elsewhere. On the other hand, we see an influx of people in just the opposite way coming to those doctors. So you'll see West Virginia plates. You'll see plates from states very, very far away in Portsmouth getting the pills, and then they go to pharmacies outside because the local pharmacies won't fill those prescriptions. We also saw the trend of docs trying to get around that check and balance system that a local health community has by prescribing these narcotics directly from their office, having bouncers to monitor things and make sure everybody's got their prescriptions in order, no nefarious intentions like knocking over the place and taking all those drugs. It's a very, very bad situation, almost like the Wild West. When I was tracking this problem very intimately and very up close and personal with it as a Sauter County coroner, one of the remarks I made 4 or 5 years ago was that Adams County probably has a worse problem than we do, but they weren't tracking the stats in the same way that I was doing it. But just anecdotally and observing ER traffic and talking to other docs, we figured they did. 2009, it turns out that Adams County does indeed have the highest per capita death rate from prescription drug overdose. So they do exceed Sauter County. On the other hand, Sauter County is where they're primarily getting the pills, because I think as we speak we have 9 or 10 pill mills there. So I would tell you that there are at least 9 or 10 rogue prescribers that I can identify.
In Sauter County?
In Sauter County, yes ma'am. And they're tarnishing as pharmacist Burke said, tarnishing the good reputation and practice art skills of all the other practitioners in the state, 99.9% of which do a good job.
There are folks that have pain that will never find relief. And the only relief they find on a temporary basis is through medication. Those folks need to be protected. Unfortunately, because of the activity that's going on today, those folks are subject to persecution every time they bring their prescription in. And Lord forbid they lose it or have to get it filled early or there's a dosage change. It's not right. We need to protect the patients that are currently ill from those who aren't. On a weekly basis, pharmacies submit their prescription data for controlled substances to the state of Ohio. And that is stored on this board's computer. Pharmacies and physicians and law enforcement have access to that data. But as a pharmacist, I can tell you, this doesn't integrate with the current system when we fill prescriptions. If you came into my pharmacy with a prescription, the only reason I'd have to go Google you on ORS, this isn't an active system. I have to log in and fire it up and log in and pull up a report and generate it and look at it, just like looking for someone on Google, is because I think you look funny. There's no queue when I fill a prescription. There's nothing that tells me you had a prescription filled just 20 minutes ago down the street at another pharmacy. No idea at all. So we wonder why this system doesn't work well. It's a historic archive. We need to prevent prescriptions from being filled in the first place. If I knew you had a prescription filled 20 minutes ago for the same product, I certainly wouldn't fill that prescription right now. That technology doesn't exist. That's what we need to have the state board pursue, because when those pills stay in the pharmacy and don't make it to the street, lives are saved.
Outside of the $150 license fee, is there other funding needs in this bill, or you have to find money somewhere to implement some of this stuff?
Some of this will come out of the existing budget. For the drug take back, for example, that would be a combination of the Attorney General, DATIS, and the State Board of Pharmacy. We're also implementing fines, as you know, on those physicians who fall outside of that classification and don't report their standing as a pain management clinic. We also, through the integration with managed care, assume that some cost savings will arrive in that. I said when I presented my ORS bill, and we talked about funding the ORS project, which we estimated to be about $2 million a year. And if we could stop one OxyContin prescription from being filled in every county once a week, we fund that program. When we spend $700 to fill one OxyContin prescription through Medicaid, and do that consistently and repeatedly across this state, how many of those prescriptions do we have to stop? And that doesn't even get into the calls that the coroners have to make to find the results of those prescriptions. So right now, as the bill stands, it is a net zero cost parity.
There's the task force had I don't know, a dozen or 2 dozen recommendations. It seems like you guys are addressing just a slice of those. Do you think there'll be more comprehensive legislation to address the task force recommendations later? What's the plan?
Well, actually, there's a lot that's addressed in here. There are major topics, but more addressed than the major topics. It's very comprehensive and a lot to move through in one bill. For example, what Representatives Burke and Bubp had proposed before focus just on orders. This is comprehensive. But again, you know, as a clinician, what I know when I treat a patient is, once you treat, then you also have to reassess. So we fully anticipate that after we field this, we're going to take a look at it, monitor it very closely, and see what needs to be done on a follow-up fashion.
And then we'll be coordinating also with the director of Odatis to start some kind of treatment process potentially for these folks. We haven't looked quite that far down the road. We know it is down the road, but to quote a saying that I always say, we're going to work one miracle at a time, and that one miracle starts today.
Okay, with that, thank you for coming.